friends. Thanks so much for tuning in. Today we're in Rochester, New York at the Flom Eye Institute, and I have Dr. James Aquavella with me. How are you doing?
I'm doing fine, thank you,
It's
Kurt.
really good to see you.
Yeah, good to see you again, too.
Yeah, it's been 3 years since I was here. So, as many of you know, I do, and by the way, my interviews are pretty loose. So we'll just have a conversation.
That's all.
Talking in front of a camera.
No problem.
For people who are watching, they know that I'm real curious about a lot of different things, especially when it comes to neuroscience, movement disorders. What I've been learning lately, the vision can be impaired by so many things can come up that can cause vision impairments. And, I know that one of the things I wanted to ask you about, I'm curious, because I know I have people who would love to hear about this. Corneal blindness in infants. And you've done a lot of work in this area. Is that?
Well, it's been one of my interests, and we are here at Flom, on the University of Rochester. Would you believe that we are the only group in the world that implants artificial corneas in babies, in infants? Okay. And the reason for that is that even though I travel extensively trying to teach these techniques, and I have a lot of people that come to visit me and they spend some time and they learn the techniques, the problem is that this process requires a significant amount of infrastructure. And for the hospital's point of view, any hospital, it's not a moneymaker.
Okay.
And so we have special arrangements here in Rochester, but for instance, it's not just me. I mean, a corneal surgeon can do a corneal transplant. A corneal surgeon can put a keratoprosthesis or an artificial cornea in an adult by himself. No problem, okay? You know, I did it.
I have one too.
Okay, yeah. But in infants, it requires a large team.
Oh.
So that not only do we have to investigate all of the factors from the birth of the infant until the time that we do. My ideal time is 8 weeks.
Wow.
But sometimes, whenever if they've had corneal transplant failures or if they've had other kinds of problems, sometimes it's later on. But nevertheless, we have to investigate and we have to get the records of all of the people. So when a baby is born with what we call congenital corneal opacity, which means a scar in the cornea that makes it blind. Now sometimes it's bilateral, it's in both eyes. Sometimes it's just in one. Sometimes it's in both, but to varying degrees.
Right.
So we like to get a report from all of the visits. So when mama, the nurse doesn't, at the birth, the nurse doesn't make the diagnosis. The mother does. Okay? Later on, when she opens the eyes and she sees something white staring back at her, rather than the usual coloration of the iris, okay, she knows there's a problem. So what does she do? She will consult her obstetrician or her neonatologist. And they'll look at that and they'll say, oh, well, this isn't my thing. I'm going to get an ophthalmologist to look at it. And the ophthalmologist will look at it and say, well, yeah, but I don't specialize in this area, so I'm going to get a corneal person to look at it. Meanwhile, there are 3 or 4 examinations, and there are 3 or 4 kinds of tests. Some of them have been under anesthesia. We need to know all of that information.
Right.
And so that takes a coordinator to get on the telephone, be sure that the medical records are all provided. I need photographs of both eyes. And then we sit around the table, and it's not only me, it's a corneal surgeon, it's a glaucoma surgeon, because glaucoma is often involved. It's a vitreoretinal surgeon, because all of these procedures involve the retina as well, because basically what we have to do is we rebuild the eye, because almost every system within the eye is involved in this destruction. So it's not only the cornea, okay? So they have cataracts, they have glaucoma, they sometimes retinal detachments, or they have retinal injuries, and all of that needs to be investigated, and we can't do anything until we get all of that information. Once we have the information, then we make a decision along with the family as to whether we should proceed to investigate. And if we do, we need to conduct what's called an examination under anesthesia.
Okay.
And so under a quick smell of anesthesia, if you will, we examine both eyes, we get the pressure, we look at them under a microscope, and we also do what we call ultrasound studies. So we get an idea as to whether the retina is intact and whether there's any cataract involved. We can get all of that kind of information. Then on the basis of all that information, we say, okay, after we've explained the whole situation to the family, do we proceed or do we not proceed?
Mm.
And then if we proceed, okay, then, we need special tissue, we need special drugs, we need special operations, we need an infant anesthesiologist, because anesthesiologists that give anesthesia for newborn babies have a different set of skills
Okay.
than an anesthesiologist that's going to put you to sleep for a quick cataract operation or something like that.
This is a seriously major operation.
Oh
no
yeah,
pun
and
intended.
then we need to order the device, or devices. So sometimes there are glaucoma shunts that have to be put in. Sometimes they're either intraocular lenses or the cataract has to be removed. And we have to order the actual keratoprosthesis, or the artificial cornea, which is like a telescope that's going to get implanted in the cornea. All that has to be in place. And then for the actual surgery, we need to have, sometimes we need a vitreoretinal surgeon and a glaucoma surgeon as well as the cornea surgeon. They're all there. And sometimes we also need a plastic surgeon
Okay.
to take care of plastic surgery affiliations on the surface of the eye. And the procedures, generally speaking, are about 3 hours, 3.5 hours. Okay, it depends on what has to be done. And then, amazing, this thing that got me involved in all of this, is you've got a blind baby, and the next morning he can see his mother,
Yeah.
and his mother is smiling.
Wow.
And it used to be, when my wife was with me, that I'd come home, okay, and I'd have all this lipstick on my face from the mothers that
sure.
the mothers that were so happy, seeing their
yeah.
babies. But it's very complicated post-operatively. It takes a lot of effort because these young babies are very prone to inflammation. They have very active immune systems, and so they can reject tissue, they can get inflammations, and we have to watch them like a hawk. And so we need coordinator to monitor them, to keep track with the family. And sometimes doctors are very busy, so they all have their doctors back home.
Right.
And one of the things we insist on is that a doctor, and usually a corneal specialist and maybe a retinal specialist too, agree beforehand that
Right.
they will look at and communicate with me in the post-operative period. And this makes be for several months.
Sure.
But they're all busy, so they
Yeah.
don't often have time to send these reports. And so we have a technician then that communicates with the family, makes certain they're using the proper medication, makes certain they're using the drops, makes certain that their scheduled return appointments are scheduled.
Yeah.
And sometimes, we do these operations in babies from all over Europe, from Asia, from India,
Yep.
from Italy, from the United Kingdom. They come from all over because there are very few places that can deal with this. And usually it's a corneal transplant, but corneal transplants in the infant often fail. And they fail progressively. So usually at the end of a year or two, almost
Why is that?
all of them get.
Is there a particular reason?
Well, it's because the infants have active immune systems, and so
Oh.
their bodies fight against the corneal transplant, and they make it fail.
Rejection.
A rejection. Okay.
I see. It just never occurred to me about that.
Yeah.
But it also never occurred to me of how many doctors you need in one OR.
It's not only
No.
one, and then you need all of the equipment
rest
that
of the
they've
people.
got. So sometimes we have 6 or 7 people around the table, and then in the operating room we might have 11 or 12 people.
Wow.
So
if you're having, let's say, are some of the doctors who are in the OR there as, it's almost like they're there in case they're needed?
No, well,
or are
no,
they always needed?
well, three of them usually are always needed, so we know ahead of time. So we
Oh,
know
okay.
if there's a question of glaucoma or whether even we're going to insert what we call a shunt, which is a pressure valve
Right.
in the eye. So we know that that's going to be necessary. We know the corneal surgeon is going to be necessary, and we know the vitreoretinal surgeon is going to be necessary because each one of these cases,
Yeah.
we have a vitreoretinal surgeon, and they do what we call a vitrectomy, which we remove all the vitreous fluid in the eye, and then inspect the retina 360 degrees to make certain that it's healthy. And if it isn't, sometimes there's laser reinforcement that gets done during the procedure.
Amazing.
So all of that has to be in place. So these, generally speaking, there are three types of surgeons, subspecialists, that are necessary for the procedure. Now, they don't have to be there at the same time. We can say, well, we're going to do this, and then we'll call you if you're available in about an hour or an hour and a half, and we'll get to your part of the surgery.
So you said your ideal time for doing this kind of surgery is around 8 weeks?
It's around eight weeks if it's a prime case and both eyes are involved. And now we have to do both eyes, because what happens is if you do one eye and you establish some level of vision in one eye, regardless of what it is, that eye is going to be favored and the other eye is going to be shut off by the brain. It's what we call amblyopia, or lazy eye.
Yeah.
So we have to do them both so that
No kidding.
they both have an opportunity to see.
Sure, because these are a highly formative time period,
Yeah.
right? So is there a window where you can't go past a certain amount of time because
Because it's variable. The brain in some infants is very plastic, so that even if you've got a child that might be even 3 or 4 or 5 years of age, okay, sometimes you can do that surgery and it works beautifully, and the eyes they adapted. The brain is plastic.
right?
In other instances, the second eye that we do at 6 or 8 weeks, okay, right, they develop a deep amblyopia, and it doesn't mean they're less intelligent. It just means that the brain is less plastic.
Okay.
And so it shuts off the vision in the poor eye right away. And we really do not have the expertise to be able to make that judgment beforehand.
Okay.
Okay. So
Right,
we have
right,
to
where
do.
you wouldn't know, right? You can't know
You
at this
can't.
point. Yeah.
You don't know.
So I never thought about that. See, this is why I love talking with professionals, the experts, because I never even thought about the possibility that one brain in an 8-week-old might be more plastic than another brain in a different 8-year-old.
That's right.
Or
It's just that the
8-week-old.
connections are different. Some of them, now it has nothing to do with, with intelligence or
Right.
IQ or how that brain is going to develop as an adult, okay? And in fact, it might be that the brains that are less plastic are ones that are more focused and devoted, so that these are people that are going to be, our space scientists and our engineers and our physicians. Or it might be the other way around, we don't know. And in fact, one of my colleagues, Dr. Huxton, as you've mentioned, one of the things she does is she takes adults who've had strokes, and the stroke, can destroy the vision.
Sure.
Okay. And she tries to reprogram the other eye that hasn't had the stroke, okay, to where it can perceive images using a different part of the brain, not the occipital cortex that was intended. And so she's trying to do that and has had some level of success. So
I'd say that right there is so fascinating. I mean, and so just going off track for a second, in my work with people with Parkinson's disease, one of the things I've learned from many of the neurologists and brain experts is that, we have these substantia nigra is losing, the brain cells are dying off, less dopamine's produced, so voluntary control of movement is usually impaired to some degree or maybe a great degree. But what we know in the work that I do is interesting is that we know that the brain just has this tendency to outsource. So they say, like the cerebellum and maybe some of the frontal area will just take on the responsibility.
well, that's exactly it.
Right.
That's
So
exactly what
now
trying
we're
to do.
talking about the occipital lobe, is it?
Right?
Cortex.
Yeah, occipital cortex.
That will outsource to another area to be able to perceive images, and that is absolutely mind-boggling,
It is.
fascinating. I love it.
And there's a lot, a lot that we're. In fact, one of the ancillary sciences that I don't get involved with because it's mostly a retinal function, but at any rate, and that is that individuals who don't have corneal blindness, but they have either have had severe glaucoma or any kind of atrophy of the optic nerve, or are totally blind and there's no real surgical procedure that could help them at all.
Mhm.
And so by implanting electrodes, okay, that communicate directly with the occipital lobe, and then onto a pair of glasses that's got a little video camera on it, okay,
Really?
the attempt is to try to obtain these images and then get them to interact with the occipital cortex, because it's the brain that does the seeing, it's not the eye.
Exactly.
The eye is just
right?
an appendage, okay?
Well, I just heard recently on an interview on a podcast from, I don't know if you know of Dr. Andrew Huberman in
I don't know.
Stanford, ophthalmologist, neuroscientist, whatever. He was talking about the eyes aren't just connected to the brain, but they are the brain. They're part of
It's
the
part.
brain.
It's part of the complex.
Part of the brain,
You know,
and during
the
the
optic nerve-
embryonic development and
Yeah,
things,
yeah,
the
yeah.
eyes start back further,
That's
right?
right. Yeah,
They kind of get squished
Yeah,
out.
and the optic nerve has maybe 1,500,000 fibers in it. And they are all connected
Yeah.
back into the brain in different portions of the occipital cortex. But so it's really quite involved and quite interesting, and there are so many different subspecialists that are involved with it.
Sure, yeah. So just going back, another question or two. When you're doing, so you do two eyes, do you do them staggered or at the same
No,
time?
usually about a week apart,
Okay,
2 weeks apart
so
sometimes.
pretty close.
Usually, if we're doing two eyes, we like to have the infant with us for about a month. And so
Yeah.
usually I see that it's all out. Would you believe it's outpatient? They don't get admitted to the hospital.
Really?
Yeah. Okay.
It's amazing.
Isn't that amazing? And they go home and stay with them. And actually, we have a wonderful relationship with Ronald McDonald House.
Oh, that's great.
Okay,
Yeah.
and Ronald McDonald House puts up not only the infant but the family and also siblings if they come along with them.
Gee,
Okay,
that's great.
so that works out very, very well.
Well, it's interesting because I know years ago, Tina and some others who I've known,
Yeah,
because I've been
over
coming
the
to you
years,
since
right.
the mid-'90s, since before you were here. And I've been coming to you for the shortest time of all my dozen family members you've worked on since the 60s. But she was saying how people were coming over from other countries. They'd be here for a month, and the infant is receiving eye surgery, and it's just, I find it just amazing. It's so great that you can do this. It's so great that this can be done, and to help them to see, obviously, right?
That's
And have
right.
that
Well, of
visual
course,
ability.
usually with infants who are blind, if we're not talking about getting them 20/20 vision, as you have, okay, any level of vision is going to be significantly important to the development of the child. Okay, so even if they've got damage in the retina, they've got damage other places in the eye, or it was congenital glaucoma, or so many other kinds of problems, if we can get them to see even 2200, the big letter on the chart,
Sure.
that
That's a
makes
big
an
deal.
enormous difference for the rest of their lives. And
Absolutely.
some of them, okay, now that since I've been doing this, I have a cab driver in Miami. Okay, I have
You're talking about infant
yeah,
when you worked on
yeah,
that.
right.
Okay.
I have a soccer player in Milan.
Whoa,
Okay, and I've got a couple of college students.
that's great.
Okay, now it doesn't, it's we certainly can't help them all,
Hmm.
but we can give all of them an opportunity to see. Okay?
Sure, yeah.
And even if it's lost, the fact that they have some vision early on during the developmental period is an enormous benefit to the child.
Yeah. Yeah. So
It's controversial
Mhm.
because many people think, oh well, you shouldn't do this because if you can only help 30% of them or 40% of them, and if some of them fail, there's nothing else you can do. But the whole point is that vision that you're able to give the child during the developmental period is an enormous benefit. And there are many, many people, who work in child development and psychology and psychiatry affirm this, and that they develop motor skills much better if they
Sure.
can see properly.
Yeah. So we touched on this just a little bit. I have one more question
Sure,
regarding
sure.
to the infant blindness. And we already talked about that window, which we're not exactly sure of. But is there a cutoff for you? Let's say where they get to a certain age and it's like, we can't do this.
Well, it depends.
Mhm.
It depends. There are, if it's a certain age, and they're suppose they get into be teenagers or even the mid-20s, then there might be a consideration for standard corneal transplant
Mhm.
because the immune system does not work as
That's right.
strongly in adults as it does in young children and in teenagers.
Okay.
So that might be a consideration. Also, now the last one that I did just recently before the COVID virus, because people are not able to travel during this time
Right.
period,
Right.
but was a child that was 11 years old,
Mm-hmm.
and he's seeing. He's on his
No
his
kidding.
pad, okay,
See, that's
and
great.
he's seeing on his iPad, and he's working, and that's just fantastic.
That's great. Imagine
So
that.
the point is, you just don't know.
Well, there was nothing for these kids, though, 30, 40, 50 years ago on previous, right? I mean,
Well, there was nothing for them, and
Right.
not only that, 10 years ago, even now,
yeah.
okay, people that don't have either the resources or the technology to be able to attempt this,
Mhm.
okay, they can't do anything. What can they do?
Exactly.
And also, some of the best units, my colleague, I don't know if you remember, my colleague Dr. Rao in India, he heads the L.V. Prasad Eye Institute in India. He has 1 million square feet in Hyderabad, India, and he takes care of 126 departments of ophthalmology. So it's a very large operation.
Yeah.
But their corneal people do not do the surgery there because in India the communication is difficult, the distance is long,
Yeah.
and it's very difficult to supply the appropriate post-operative care in that environment.
I see.
So they have stopped doing it in that case.
No kidding. Wow. And where is that in India again? I haven't
Hyderabad.
been to that country
Hyderabad.
yet. Okay.
Hyderabad is the Silicon Valley of India.
Okay. So I just had one other thing I'm curious about. What's it like for you to have all this happening, given that your career has been amazing? I mean, he knows my whole family. We've got Gail Parsons back in the mid '60s, the first cornea transplant of my family, and you did that. Joanne Waters, Lula, her mother,
That's right, sure, I got it.
Corrine.
That's right, I've done them all.
So my family and the lattice dystrophy situation, but that's aside. That's just a side note. But what I'm looking at is, here's how I could set this up. Actually, so my dad had his first transplant in 1970. Dr. Ken Spitzer, Ken.
Yeah, I know.
So I remember he was in the
Sure.
hospital for 6 days,
That's right.
and he had a patch on for 90 days. He was out of work. I come in 2003. I have a donor tissue transplant, and I'm back to work 3 days later, driving my car.
Well,
What's it like to see these changes for you over the years?
Well, yes, but it also involves the changes in medical practice, and it's an individual. So, for instance,
Mhm.
right, my colleague Dr. Rao, who was my right arm for 12 years, he was
Mhm.
my
I remember
assistant. Okay, all right. So he and I, I think in the late 1970s, okay,
Mhm.
we published 100 consecutive corneal transplants in which they were done on an outpatient basis.
Oh, wow.
Okay, and the whole of my colleagues in cornea were horrified. How could you possibly do this? Because the standard of care at that time was a week in the hospital.
Yeah,
Okay.
I remember that.
Right. But now, of course, everybody is doing it that way, and they found out that, staying in the hospital does not mean anything, because you have nurses, generally speaking, in most general hospitals who aren't trained in ophthalmology.
Mm-hmm.
Very frequently, you don't even have residents there to do it.
Right.
And if a patient of yours has pain in the eye, somebody's going to give him a shot for a narcotic in the middle of the night, and you're not ever going to know anything about it.
Right.
So, and the fact the doctor would come through every day, take the patch off, look at the eye, and put it back again. And he wouldn't have any tests or any equipment or anything to do it with. So we found that on an outpatient basis, the patient would return to our office where we had all of the technology that we needed
Sure.
to be able to examine the patient, and we had trained personnel to be able to do it. And so that made a big difference.
So I didn't know you did that in the set. That's really interesting.
Well, no,
Well, you know, and it even says more about why I came to you in the first place is because, well, Jody told me, Carl, you got to go. He's the man. Because he's literally, and you're on the cutting edge. You're always out in front. You're a leader in the field and raising the bar. And I appreciate so much what you've done for the world, my family, for me.
I was the first corneal surgeon to be trained in a fellowship in the United States and currently in the world.
No kidding.
Okay, so when I finished my residency in ophthalmology in New York in the early '60s, okay, I thought I'd like to know more about the cornea, because I had seen a couple of corneal transplants, one done by Ramon Castroviejo, who in New York was the preeminent person who had done that, but most of them failed, okay.
Okay.
And then there was a local individual that I worked with called Benjamin Rizzuti, and so they impressed me. And this is no microscopes, nothing. It was all done with a pair of magnifying lenses.
Oh,
right?
man.
And and so I wrote to Harvard and the chairman there, and he said, no, we don't have any program. There was no program. He said, however, we've got a new young guy here who just came over from Sweden, and he's interested, and why don't you come up and talk to him?
Mm-hmm.
So I did, and we established, he was my mentor for a while, and since, a colleague, a very, very good friend.
Mm-hmm.
Klaus is exactly 10 years older than me, and he's now almost 90 years of age.
Mm-hmm.
I mean, almost 100 years of age.
Okay.
Okay, and he's still going strong. But so we established the first corneal fellowship program at Harvard and at Massachusetts Eye and Ear Infirmary in early 1960s.
Wow.
Both on the research side as well as on the clinical side. And then I've been in Rochester since 1962.
Isn't that something? That's great. So is that anything having to do with, wasn't there a relationship between here and Boston Eye Clinic or Boston something? Does that have to do with what you set up out there?
Oh yeah, well the number one, there also was a good friend of mine who actually was a resident when I was a fellow at Harvard and at Massachusetts Eye Infirmary, Dr. Perry Rosenthal, okay? And he was very much involved in the complexities of the innervation of the cornea of the eye and how that would produce difficulties in people who had dry eyes and things like that.
Mm-hmm.
And he was always thought of being on the fringe, and nobody paid any attention to him.
Mm-hmm.
And all of a sudden, 30 years later, people recognized that his concepts were important, and he established what was called the PROS contact lens. And it was a scleral lens that fit over the surface of the eye that people with dry eye and severe corneal disease would be able to wear almost full time, and also be able to see when no other vision was possible. So this was without surgery. And so he came back and he established that, and we then were one of the first institutions to work with Massachusetts Eye and Ear Infirmary and to develop that technology here. And we now have Dr. Vaz who does that and does related types of contact lens work.
Interesting. Also fascinating how far it's come. So it just brings up other questions, though, just a couple little things.
Sure.
Like, for example, and I could be wrong, but I seem to remember that these sutures that my father had in 1975. I think they were different. They might have been thicker or something, right?
Sure.
So
Well,
is that a different? Does that help with the recovery time now?
The first corneal surgery that was done by Dr. Castroviejo in probably in the 1940s. Okay.
Wow.
There were no sutures. Okay, and so what they would do is at first they would put an egg membrane over the cornea, and they would patch it tightly and hope that it would heal, or and often many of them failed. And then later on he developed a technique in which he would cut, rather than a circular piece of cornea, he would cut a square graft so that it could be anchored in the corners of the eye, and so he wouldn't have to be suturing all of that way through, and that worked too. But the suture material, when I first started to be interested in, we used my colleague, both Castroviejo and Dr. Rizzuti, they would go to Sweden, okay, and they would use needles that were made by Grieshaber Company, and they would swedge them onto, okay, the hair of blonde women, okay, long hair, and they would use that to suture with.
Wow.
Okay.
That's
because
a mystery I had no idea
the
about.
suture material that was available to ophthalmologists was very, very thick, and you couldn't see out of the eye for all of the sutures. Okay.
You could have
and everything was large and gross. And after that, we began to use what's called nylon 66, and it was the first using very, very thin nylon thread, which has been the standard for corneal transplantation now for the last 40 years, 45 years.
That's amazing. I learned a lot today about a lot of things. I had no idea about that history. And then, wasn't there something in the early, well, I don't know when, something about pig skin or pig membrane?
Oh, no, there was one of my French colleagues, okay, Dr. Paul Perrault, who did research with me at Harvard when I was doing a research fellowship there. And he had a concept. And one of the most distressing diseases of the eye was what we called bullous keratopathy. And what meant that the corneal endothelium would fail and the cornea would swell, and because it swelled, it lost its transparency.
Okay.
And so his concept was, I want an elasmobranch shark, because sharks live in salt water.
Okay.
And consequently they were able to pull the fluid, their tissue was able to pull the fluid out from the cornea.
Oh.
So his concept was to transplant shark corneas, okay, in individuals, in humans. It never worked, but at any rate, it was a concept.
Interesting. Wow. So many things. Well, I'll tell you right, these days it's amazing to see how far so much technology and has helped us, and just things you keep learning about, right? All this stuff about the brain is fascinating too, as far as retraining and that
wonderful
thing you talked about back here that can communicate with.
Oh yeah, all of those are, and they even have they're trying to do it with a skull cap, and so they're trying with a skull cap that's got some electrodes that would preclude. Although I think most of the technology is going in the way of implanted. Well, there are a lot of things we're implanting today. I mean, there are cardiac valves.
Sure.
They've got implanting stimuluses, so people that have to use a CPAC at night, they don't have to use a CPAC. They just hit a button,
sure,
and it stimulates their breathing.
There's
so many things that we can do.
We even have. I've met many people around the world with Parkinson's who have the pump implanted to pump out dopamine.
Yeah, right.
Duo something pump.
Yeah.
And for many of them, it's really helped to keep them in more of an on period of movement, a higher function movement, because they're not having the crash from the dopamine wearing off or Cinemet, right? And they don't have to wait for it to kick in because it just goes in through the pump. Amazing stuff.
Well, the Department of Neurology here has been preeminent in the field of Parkinson's. I don't know if you know that.
I do.
Interviewed
and I need to work my way in to talk with some of those people at some point. you have any connections.
Oh, yeah, no, I do. We have. I mean, we work very closely
Sure.
with them.
Yeah.
We have neuro-ophthalmologists that have joint appointments with the Department of Neurology.
Yeah. So after, well, not that you need to know folks, but I am looking at graduate programs, and the first place I'm looking is here.
Well, that's
So
right. So once you're based here, you would be able to have access because
Yeah.
the research program here in ophthalmology, we collaborate and coordinate not only with individuals all over the Institute of Optics, for instance.
Sure.
Right, we have 124 PhDs in the Institute of Optics. It's one of the preeminent
Yeah.
optics institutes
Mhm.
in the world. And we work very, very closely with them. We have the Center for Brain Research, very,
Yeah.
very closely with them. We have CVS, the Center for Visual Sciences,
Mhm.
which 24 to 26 PhDs just doing visual science work. And so all of this is collaborative. And we also collaborate with other people on what they call the River Campus, so they're engineers, they're scientists, they're
Mhm.
electricians, they're everything else, chemists,
Yeah.
and then other institutions across the world.
It's really exciting to think about, and that's why the nerd and the geek in me needs to get back to school because, after all this stuff with Parkinson's, and then just being with you and going through a couple of the donor tissue thing and the K-Pro implant, and just knowing about some of the things you're doing, to me it's just so fascinating. So that's another reason I want to talk to you today, which I really appreciate your time.
Oh, my
I greatly
pleasure,
appreciate it.
talking to you. It's always good
Thank
to
you.
see
Hey,
you.
you too, my
Good
friend.
to see you again. Take care.
Good to see
And
you.
I hope to be seeing you soon in our own home.
Oh yeah, I will. And thank you, Dr. Aquavella. Thank you, everybody, for watching and listening. And my brain's on fire here. It's great. Thanks a lot. Have a great day.